My case is a complication during SFA angioplasty. This was a 60-year-old gentleman, professor of economics from Mombasa, Kenya. He was post-PTCS stenting to LAD and LCX in 2002 in the United States. Then he had claudication pain, both lower limb, for 6 months. And then he came to us. Coronary angiogram revealed both stents to be patent. Peripheral angiogram revealed right SFA 100% occlusion with reformation and significant aortoiliac disease on both sides. On 6/7/2006, he underwent PTCS stenting to right SFA. Through right femoral antegrade approach, the CTO was crossed by subintimal tracking, and after pre-dilatation, he was stented with 3 Taxus drug-eluting stent and 1 express stent. Then 4 days later, on 10/7/06, we took him up for aortoiliac bifurcation stenting with kissing stents. A bridge assurance 9x60 and express 8x57 were placed. There was a dissection at the lower end of the right iliac stent, which was overlapped with Genesis stent, and there was good end result. Patient went home fine. 2 years later, he again came with claudication pain over the left calf since 1 month. Enjoy. Check angio showed all the stents to be patent. This is just to show the stents in the SFA and the stents in the aortoiliac bifurcation.
Otherwise you can't get these things.
And now the problem was a focal lesion in the left SFA. Go to the next.
No.
The drug-eluting stents on the right SFA were patent. There was mild restenosis in the upper express stent, whereas the aortoiliac stents were patent. Next. So for the left SFA, since he had stents in the aortoiliac region, we had to go through a left femoral antegrade approach. And that was the lesion. Go to next. So we pre-dilated the lesion with the 4x20 Gazelle balloon. Next. And then we decided to stent with the 6x40 biotronic stent. There was a dissection, so we didn't want to leave it. Next. So this was the stent placement. We could see it was covering well the lesion. Next. And after deploying the stent, what we found was, after deploying the usual way, the stent had fallen down and it had shrunk. This was the size of the 40mm stent. Now it had not only fallen down from the lesion, now we needed a longer stent to overlap this and then cover this lesion. So we needed at least a 60mm stent, but we didn't have a 60mm stent in our shelf. So then we had another smart 6x40. So then we first overlapped the 6x40. Next. Smart stent. Next. So this is the 6x40 smart stent with overlap below of the biotronic stent. Next. You can see obviously there was some lesion above. So then we didn't have a self-expanding stent, so we had to cover this with the renal stent. We did it with the 6x18 AMIA stent. Next one. So, I mean, this is just to show that this is a 40 millimeter stent and this is also a 40 millimeter stent. We did not know why this stent shrunk so much and fell down. Next. And there is the final picture. I would like to know from the panel as to why the stent shrunk and fell down.
What I have a feeling in this case is that altogether the stenting, Michelle, do you agree with that, that as in coronary here also we should do the stenting from healthy to healthy segment? Because that perhaps we missed in this particular case. And that is, you may have to overlap 2 or 3 stents, but a focal stenting in these cases, they don't help in the long run.
When we use the pre-dilatation balloon,
even
which was 20 millimeter,
there is proximally still quite a disease segment is left. No,
okay.
I've seen.
Okay, but why did the stent shrink so much? I mean,
that is.
Dr. Henry is there, and before you, RD.
No.
Yeah, continue, sir.
No, maybe it's not similar to coronary, because a femoral is sometimes very diseased with long diffuse disease, and it's difficult to stent everything if you don't have a significant stenosis. In that case, I think the stenosis was very focal. So the stent jumped, if I understand.
That's why it jumped.
Yes, it jumped, yes. So I think that you deploy the stent very quickly. When you open a stent, you have to open very, very slowly. All nitinol stent. I don't know one nitinol stent who didn't jump. All nitinol stent jump. So you have to open very, very slowly. And after that, if the stent jump, you can pull back a little bit the stent and place the stent where you want. If you open slowly, you don't have any, you have jumping, but you can recuperate in the good place. So pay attention to that. Never open very quickly a stent.
So why your stent has shortened? It's the volvulus of the stent. I have similar experience with the other stents of the nitinol variety. This is a volvulus stent inside the stent. That's why it's a shortened, and if you'll see your angio, there is a more intensification of the stents. I mean, the stents are better seen where it is overlapped. It is volvulus is there it is more better seen. If you show the angio again, people will be able to know it. That's why it occurs. It's a volvulus inside the stent. Distal part, proximal part get volvuled.
Sure. So I think.
Yeah.
Oh.
Just show the
Yeah.
stent inside just before that.
Yeah. This part.
Before you have placed the other stent, just first stent, show the first stent. You see the stent opacity is much more in the proximal part than the distal part.
Yeah.
So that is the volvulus inside the stent. We have similar experience with the other group of stents, which I have used, and similar it has enfolded inside. Then we dilate it well inside the balloon. So it, when you push the catheter, any catheter, it goes inside, push inside, and cause volvulus.
Was this the last case, or is there anything else? No? Okay, then it was really a great experience in this session, and what altogether I am seeing since yesterday, that how much we have advanced in the peripheral vascular intervention, and it is a great pleasure to see this, and so I think that we can close this session, and after this we have There's practical experience and all, so we have to move out of this place. And before I finish, I would like to hear from Dr. Michel Henry only one thing, that after carotid stenting, that after deployment of the stent, where do you avoid doing a post-dilatation? Are you satisfied if a 20% residue is there and all? Because post-dilatation is the time what hypothetically we believe that the maximum embolization possibility is there.
Yes, you have to dilate, pre-dilate or post-dilate the stent. I don't predilate in maybe 90% of the cases. That means that I have to post-dilate. That means that I post-dilate 99% of the cases.
Oh, so you prefer post-dilatation?
Yes. Yes, but I agree with you, it's maybe a risk. But in fact, if you have a good protection, if you clean up the inner part of the stent, the complication rate of, I have now more than 1,000 carotid angioplasty, and we can do a carotid angioplasty with less than 1% neurological complication. And all our patients are controlled by neurologists. So it's not 1% like that. No, it's really less than 1%. So the complication rate of carotid angioplasty, if you are experienced, is very low. Very low. But I have no time to present some slides, but you have to pay attention to choose your protection device, to choose your stent, and to have a good technique and experienced operators and good technician to help you. But if you have everything, believe me, carotid angioplasty is a very, very safe procedure. So, post-dilatation, I don't think it's a big problem. I post-dilate 99% of the cases, and I agree, 20% of residual stenosis is nothing for a carotid. It's not the same as for coronary. You can leave 20-30% of residual.
Particularly these self-expanding stent, they go on continue to expand. So that's why I thought. Just take your advice.
I totally agree.
Okay,
and sometimes in calcified lesion, it's impossible to expand the stent, and it's better to leave 30, maybe 40%.
Okay, thank you very much. So, end of the session. You wanted to say something? Yes, please come. Please come to the mic and tell.
Because you must dilate, fully attach it, otherwise the problem will be thrombosis.
Okay, that's why we are asking him.
Thrombosis, acute thrombosis within 24 hours, the stent thrombosis will be higher if you have not expanded it well. That is the reason.
Yes, but the stent thrombosis...
At the risk of embolization. While you are dilating, the risk of embolization.
Okay, thank you very much. We end the session.
Dilating, not attaching the stent properly, the risk of thrombosis and stroke in the first 24 hours.
Yes, but the stent thrombosis is very, very, very rare.
Yeah.
I had one.
Yeah, but that is the problem if you have not expanded it.
Yes, I totally agree. You have to expand.
Yeah.
Yes.